esteemed panelists, good afternoon. I would like to thank the organized committee to invite me to be with you in this beautiful event to present this case, which all about 72 years old lady, overweight lady. She had history of diabetes mellitus and hypertension for the last 15 years, and recently she has been shifted to insulin because the blood pressure is not well controlled. She is overweight. She has history of COPD, and she quit smoking a few years ago. She has poor mobility because of severe bilateral knee joint pain, and there is no any family history of ischemic heart disease. This patient had been admitted 1 month before the procedure with non-SCACS, and the ECG, when we saw the patient after 1 month, there is no any significant change in the ECG. The echo was good with good LV systolic function and no any valvulopathy apart from moderate pulmonary hypertension. She has got high HbA1c and mild degree of CKD. This is the baseline angio. If you see, there is a diffuse disease left main stem, and we have got diffuse disease vessel. Have a look on the extent of the severity of the lesion, and we have got calcification of the mid LAD, and the red row showed the calcification and the length of the end of the calcification, the LAD, by dry staining. So this is the baseline angio showing severity of the lesion in the LAD involving the small diagonal, left main stem, and diffuse disease LCX. And the right coronary artery, this is another projection. This seems to be severely typical for diabetic lady in this age. And the right coronary artery was dominant as no significant lesion above from some non-stenotic lesion. Actually, the syntax score was high. It's around 34. And syntax score 2 also was high. However, because the patient is immobile and she has COPD, it was in favor of bypass surgery. And honestly, this patient had been, and the surgical Euro score was intermediate, 6.3. And actually, this patient had been sent for CABG because this is a classical teaching when you have got diabetes mellitus, patient two vessel disease. Honestly, the patient in this small vessel, one of the options is CABG. But the patient had been declined by the anesthesiologist because of the bad chest, and there is that heart team discussion done, and the decision one to do PCI. So in this case, how to plan for that? How we do debulking? Because we have got from angiographically, there is severe calcification in the LAD, and what type of scoring balloon or rotational, IVL or orbital atherectomy. So planning upfront two-stent strategy or single stent and provisional stenting, and what about the imaging? This is the algorithm that had been shown yesterday. This is a very good algorithm to determine which kind of debulking you will use. And this is if we have got either deep calcification, superficial or nodular. This is a rule of 5. If you have got by OCT, if the thickness is more than 0.5 millimeter, the length is more than 5 millimeter, and 50% of the circumference have been involved with each one have 1 point, while in the IVUS the same is 0.5. The thick when we have got length more than 5, and we have got 270 degrees circumference involvement. If the patient have got 3 point, at that time you should go for either IVL, rotational, or orbital atherectomy. If the patient have got only 2 point, at that time scoring balloon or OCP balloon can do the job. In this patient, because we have got the IVUS done showing severe calcification in the LAD, and at that time, so from dry angio and from imaging, it's clear that the patient have got the length of the LAD is more than 5 millimeter, the calcium more than 27 circumferential, and so we have got different tool, whether we choose orbital, rotational, or IVL. So the assessment of the calcification is very important. It can be done by CT angio. However, it's underutilized by dry angio. But the best tool till now for assessing the calcification is by imaging. So this again algorithm how to choose the device, and I think that yesterday a lot of presentation about that. If you have got severe calcification, definitely you should go for the IVL or rota or orbital. One of the beauty of the orbital atherectomy is can be done for diffuse disease calcified lesion with the difference in the diameter, like the case have been done by Dr. Ariani yesterday. So the strategy for this case is to go from radial artery. All the time we are doing this procedure from 6 French radial artery sheath, because one balloon, one stent, and decay crush can be done easily from this guide. So with using we have chosen for this patient rotational atherectomy with 1.5 burr at the speed of 180,000. So we have started with doing rotablation for the mid LAD. You can see the extent of the calcification is 1.5 burr. And later we have started to do pre-dilatation. And upfront we have decided to do decay crush. But honestly, this case have been done back 1.5 years ago. If I'm doing the case for the time being, I'll never put this strategy. I'll never put a stent in the LCX because it's small and diffuse disease. I'll go with the DCB. So after that, we are going to do pre-dilatation. One of the important points after doing debulking is you should have a good lesion preparation. One of the things that you should have one-to-one size of the balloon. NC balloon one should be one-to-one to the reference diameter just to have good preparation. This is the normal step of the decay crush. As mentioned yesterday, 17 steps. All steps have been done. We have implanted a stent in the left mainstem LCX 275. It was 275 30 something like 34, and crushed with 3O balloon, and good preparation of the LAD. And this is the first question. Later followed by the implantation of the stent involving the ostium, because the ostium of the LAD is left mainstem most seems to be involved. And these are the normal steps of the decay crush, which is important to do all the steps, because if we are not going to do good crushing of the stent, possibly will not can cross, because as mentioned yesterday, about 8% of the cases that you cannot cross the struts. And one of also put done by 4.5 12, and aortoostally is very important. I remember 10 years ago, one of the pioneer of the field told me that even if you don't have IVAS, you can do PCI for the left mainstem, provided you will do a very aggressive pod for the left mainstem. So 4.5 at 22 bars, and this is the final result, and the IVAS show good result. This is the final result of the case. And the circ seems to be diffuse disease, however, it not seems to be bad. So I have only one of the important points is that still we have a lot to learn about calcium. I think that about the density, about the volume, hopefully in the future technology will help us how to deal with the problem. Another important point is the assessment. The same story for CTO, how we have a case of the CTO, we are going to have a look on the CD to see the collateral. We have a plan. Calcification, you should have a plan. You should never do it ad hoc. You should have a plan. You should have all the tools. Another important point is tool selection and aggressive plaque preparation. And lastly, we have no evidence-based algorithm. We have a lot of algorithm, but it's not one is in the guideline. The last one is the best is the enemy of good. Do not aim for perforation. And thank you.